Yeah, I think I stopped sharing, right?
Good evening, everybody. To all those who have logged in tonight, we are continuing the tradition of the Amasi online CMEs, which are held on the first or the second Thursday of every month. This is the seventh Amasi online CME, which is being held. Today we have a very interesting topic on rectal prolapse and rectal floor, the pelvic floor dysfunction, a common problem for all general surgeons all over the world. We have an eminent lineup of speakers and renowned moderators. But before we start, I would like to invite Dr. Varghese for his comments. Dr. Varghese is the president of MASI, the Association of Minimal Access Surgeons of India. Dr. Varghese, please.
Thank you, Dr. Rajdeep, and welcome to the Amasi Online CME series. This time we are doing in association with the Society of Surgeons of Nepal. And we have Dr. Bigal here representing Nepal and as a moderator of today's session. And we have a galaxy of speakers, both international as well as from this hospital. And I'm sure that today's the talks is going to be very good and there will be a good discussion. And also there will be a usual quiz program, which will be done by our Secretary, Dr. Deboshi Sharma. And the moderator is Dr. C.P. Kothari. Welcome, sir. And as mentioned that we have the senior professor, Dr. Professor Pichumani here. We are lucky to have sir here. We heard so much about you and thanks for joining for this CME program. And then we are also coming out with online surgery program once in a month, that is every Thursday. And the first program will be done on the coming Thursday at 3 p.m. And Dr. Parthasad and Dr. Roshan Shetty is going to be the coordinators for this program. So I invite all of you for this coming up program. And the first program will be done by our founder president, Professor Palanivelu sir, on right hemicolectomy. There will be a live demonstration of the surgery. And it will be very interesting. I request all of you to join for this program. So once again, welcome to all and over to Dr. Rajdeep.
Thank you very much, sir. And I would like to invite Dr. Deboshi Sharma, the Secretary of the Association of Minimal Access Surgeons of India, for his comments. You are muted.
Thank you, Rajdeep. Thank you, Varghese sir. A proud privilege and honor to be among all of you, some such eminent faculty from around the globe today. As a secretary of the association, I'm supposed to declare the quiz results of the last CME, which was held on the 1st of June, 2023. And we have got two winners from there. First is Dr. Govind Desai, who is a GI surgery third year MCH student from KEM, Mumbai. Do we have Dr. Govind here with us today?
Yes, sir.
Yes.
Good evening, sir.
Congratulations, Dr. Govind. Very nice to have you with us.
Thank you, sir.
Wish you all the best in the future. You answered the first question right. And the second, we have Dr. Rajik Reyes, who is a senior registrar in gastroenterology, working in National Hospital, Kandy, Sri Lanka. Welcome, Dr. Reyes. Dr. Reyes, are you there? I think Dr. Reyes was also there. Both of you are...
hello, sir.
Dr. Reyes, congratulations for winning the Amasi quiz.
Yes, sir. Yes, sir.
Held on
thank you very much, sir. I'm really honored to be the recipient of this award. And thank you very much, Amasi, for the enormous...
Thank you. Welcome to the Amasi poll.
Hello?
We are really happy that you all participated and that...
Hello, sir.
Yes, you can say.
Hello, sir.
Yeah, we can hear you, Dr. Reyes. Okay, thank you, Dr. Reyes and Dr. Govind being here with us. And mostly we are thank you because you participated. You are
yes, sir. Eligible. Thank you very much, sir. Thank you.
You're eligible for...
I'm really honored to...
we have heard you, Dr. Reyes. We move on with the CME, I think. You are eligible for the certificate from MASI, which will come.
Yes, sir. Thank you very much, sir. There is a signal.
Come to you online, and you also will get a 5,000 rupee transferred to your accounts, which is a normal routine. Now it is my duty to ask the first quiz question of this CME, and we will display the quiz question for less than a minute, but the answer will be open for around 3 to 5 minutes. So a ventral rectopexy, I think all of you know, what is the main advantage of a laparoscopic ventral rectopexy? That is the first quiz question. We expect all residents, all registrars who are joined in, junior faculty, to answer this question, and whoever answers it first will be awarded the prize in the next year. I'll ask the second quiz question at the end of all the 4 lectures before the discussion starts. I expect all of you to be there till that time at least. Thank you. Thank you. Over to Rajdeep.
Thank you very much, Dr. Debarshi Sharma. And we will start, and I have pleasure in introducing the 2 moderators for the evening. First, we have Dr. C.B. Kothari. He's a senior consultant surgeon at Care Hospitals, Indore. He's a colorectal surgeon, advanced laparoscopic surgeon, and he does a lot of advanced GI surgery also. He has been, for us, he's been the Central Zonal Vice President of AMASI in the past, apart from being a governing council member of the Association of Surgeons of India, the state president of ASI, state president of IMA, and he has also been awarded the BC Roy Award by IMA. We have another moderator with us, Dr. Bikal Ghemere. We are very much honored that he has agreed to participate in this. He's an associate professor, GI, hepatobiliary, laparoscopic surgery at the Institute of Medicine. He's also worked at other hospitals like the Chirayu Hospital at Kathmandu, Nepal. Thank you very much, and over to the moderators.
Thank you, Rajdeep, for a nice introduction and inviting us to moderate this session. And it's my pleasure to introduce the first speaker, Dr. Sanjeev Patankar. He is an internationally renowned colon and rectal surgeon and practices in East Brunswick and affiliated with St. Peter's University Hospital. He received his medical degree from the St. G.S. Medical College and he is known for his laparoscopic and robotic surgical skills. Teaching, clinical research, and innovations are his passion, and he has emerged as surgeons of surgeons. Now I invite Dr. Sanjeev Patankar to deliver his talk on rectal prolapse.
Thank you very much for the very kind introduction. Let me share my screen, and to start off, let me say that I have now focused, all that was correct, but that was few years ago. I now focus on giving back to my mother country. And for last several years, I have been doing work as a visiting professor, as a head of the academic section at Valavalkar Institute in Chippadurn, as well as the King George Medical University. And that would be of great interest in the last 10 slides that I'm going to show to you. I also look forward, and I thank you. I thank the AMASI organization. I will be there at Raipur. I have been invited to give a talk. The talk has not been assigned, and I look forward to seeing a number of you guys at Indore at the accuracy conference. So let's talk about rectal prolapse or procedentia. We have a lot of things to cover. The standard definition is the protrusion of the entire thickness of the wall of the rectum through the anal sphincters. But as we will see later on, we also have what is called as a mucosal prolapse, where it is not the entire thickness that prolapses. Etiopathogenesis, these are the 2 main theories of rectal prolapse. Whether in reality, whether it starts off as a sliding hernia of the anterior wall of the rectum, and this has been proved by anatomic observation of the deep pouch of Douglas, as well as from the cine radiographic studies, or whether it is an intussusception that starts few centimeters above the anus. It really doesn't matter. Anybody who had seen even a single case of a transanal Altmaier's, the proctosigmoidectomy, immediately realizes that there is a intussusception, which is what a complete rectal prolapse which presents outside is. The pathologic anatomy is quite important for us to know. And the reason for that is that it is of great relevance when we are operating on the patients. There is a diastasis of the levator hiatus. There is redundancy of the rectosigmoid colon, deep cul-de-sac, as we saw earlier. Anal sphincters become patulous. The endopelvic fascia is weak, and there is loss of normal horizontal position of the rectum. Of importance, one should know that fecal incontinence could be associated with rectal prolapse. The incidence has been reported to be between 35% to 100%, depending on where the series comes from. It is important to realize that it is multifactorial. The various factors are constant stretching of the sphincters by the prolapsing rectum. There are rectoanal inhibitory reflex elicitation abnormalities that have been noted. There is reduction in rectal compliance on manometry, and pudendal neuropathy, which has been ascribed to the stretching of the pudendal nerves as a result of the rectal prolapse, whether it is primary or secondary or both, is not very well known. The standard textbook statement is cause and effect relationship is uncertain. But in clinical practice, what we do observe is that fecal incontinence decreases or completely disappears after successful repair in most patients. So in fact, one of the standard board answers is, if a patient presents with both, what will you do first? You repair the rectal prolapse first. After a few months, you reevaluate, and then you go forward. It is also important to think in terms of the pelvic floor. Although if we, as in US, are practicing purely colorectal surgery, it is still very important to make sure that you look at the urinary aspects, the uterine aspects, and get the appropriate specialists involved. So as I said earlier, the standard clinical classification is incomplete and complete. Incomplete is only mucosal prolapse, and complete is in 3 degrees. The first degree is occult or invisible, and these are the patients that present with the obstructed defecation syndrome. Second degree prolapse, rectal prolapse, it's full thickness, but it is visible on straining. And third degree is the externally visible without straining. It is strongly recommended, and I really want to stress that it is extremely important to document the preoperative fecal incontinence status, whether it is present or absent, and choose any of the fecal incontinence scoring systems and document the degree of the fecal incontinence. As I said, ask the patient whether they have urinary incontinence, associated stress urinary incontinence, document that. In female patients, document whether there is associated vaginal and or uterine prolapse, bladder prolapse as well. Because if they have these and you simply focus on rectal prolapse repair, patient is not going to be a happy person. The clinical differentiation is pretty straightforward. These images are from my own authored book chapter. Dr. Pichumoni, who is present, is one of the editors, and this is published in Geriatric Gastroenterology. It's a 3-volume textbook. So on the left-hand side, we have the complete rectal prolapse. We have some residents and fellows. So these are questions that we ask. How do you differentiate? Once you know, it is simple and straightforward. But for complete rectal prolapse, you have circular folds of mucus. Then there is a sulcus here that you can clearly see. You can palpate the full thickness of the rectum that is prolapsing. I think seeing this particular image, you will never make a differentiation. You will never be able to fail to make a correct diagnosis. On this side is prolapsed hemorrhoids. They could be worse, but with prolapsed hemorrhoids and mucosal prolapse, what you have are the radial folds of the mucosa or the anoderm. I'm going to come straight to the management because a lot of important things to cover. What I want to point out is that there is a decision tree algorithmic process that I'm going to explain. In the textbooks, there is a almost like a menu card description of this procedure, that procedure, this person described, that person described, various eponyms, and then we get confused. I'm going to cut right through that and I have put together this decision tree algorithmic process, which helps us clinicians in every situation. So of foremost importance is establishing correct diagnosis, then the grade, which is based on talking to the patient, document associated fecal incontinence and its grade, evaluate for associated pelvic organ prolapse. I would say use clinical judgment and do at least a flexible sigmoidoscopy. Many of our patients who are elderly have had colonoscopy for prior screening, and then if they come with rectal prolapse and have no other issues, it's not necessary to put the patient through a full colonoscopy. I would say use judgment. Anorectal physiology studies I always obtained for baseline, and one of these three studies is worth doing for documentation, either MR difficography, CNA difficogram, or the triple ultrasound that has been well described. And Dr. Mantu is an expert on ultrasound, and he might be able to comment on that. It is after this, it is very important to determine the patient's physiologic reserve. And please note, I'm not saying fitness for anesthesia. You want to ask the patient, can you go up? Are you able to walk? What is the patient's mental status? Are they able to climb a couple of flights of stairs? These are the things that will help you as the surgeon come to the next decision tree. Obviously, talking to the patient is the most important thing. I want to put forth here, firstly, before I went into the details, my own personal series to put a perspective. So the total prolapse surgeries that I've done in roughly 15 years as a board certified colorectal surgeon were around 260. Of these, the vast majority, 200 of them were proctosigmoidectomies. Altmaier's procedure, as it is known, also called as perineal, but it is really a transanal procedure, as you will see. Abdominal procedures, I performed all of them minimally. I personally don't see, if you are trained, why anyone would want to do this operation open. So it's only lack of training as a laparoscopic surgeon that one would do this procedure open. So for me, the 60 procedures were all MIS, abdominal procedures. Now, please note that they represent a very tiny proportion of my colorectal resections, just 60 out of 1,800 or so. The rectopexy and resection rectopexy percentage is 75 to 25. The laparoscopic, I did roughly 30 laparoscopic, and later on when robot became available, I started doing robotics. And it's a wonderful approach to do it. Again, the 20-some robotic cases represents a tiny percentage of my robotic resections. The combined total pelvic floor repair was around 10 patients. All of them were done robotically and with a urogynecologist. The trend that I observed was towards, as we progressed, towards less and less resection rectopexy. I have to admit, and I'm going to talk about the problems of posterior rectopexy. That was a wonderful question that you guys framed, and at the end of this talk, everybody should be able to answer, but it reflects US practice and our US-centric issues, though I have become more globalized now. So these cases also reflect the US demographics. For Altmaier's group, my mean age of the patients was 85, range from 75 to 102, numerous comorbidities. I would say that there was one notable outlier, a 35-year-old female. Later on, if there is time, we can talk about that. Again, I want to point out that although principally I am and was a minimally invasive surgeon, I chose the least invasive Altmaier's operation in the majority of patients. The major outcomes are put here in the box. They are excellent outcomes. Altmaier's recurrence roughly 8%, anything less than 10% is pretty good. The Clavian Dindo grade 3 complications were uncommon as well. Abdominal procedures recurrence rate was much less. So here I'm putting a big picture summary, and then we will go into the details. Most important is there is no medical treatment except the anti-edema measures to allow reduction of strangulation. How common is strangulation? Extremely rare. I have seen only 2 patients in my lifetime, and I would say that one should always plan on elective surgery. Now, I'm not going to discuss about the mucosal prolapse. Mucosal prolapse is essentially treated as if it is a 3rd or 4th degree hemorrhoid, rubber band ligation, injection sclerotherapy, or procedure for prolapsed hemorrhoids, which is stapled mucosectomy. If it is full thickness, and again, I would like to share here that I never did any obstructed defecation surgery. Somehow I always extracted myself out of that situation. So the internal grade 1, grade 2, no, all of my patients that I have put earlier were full thickness, 3rd degree, external, obvious prolapse. If the patient presents like this, as I said, the next major decision node is patient's physiologic reserve level. Is it good, poor, average? Then you help the patient to make a choice about what they can tolerate, the durability of repair, recurrence rates, functional outcomes, and cosmetic results. At the outset, I would say there is absolutely no place for Thiersch or any similar variants. And why is that? As you realize that the prolapse starts few centimeters above the anal verge, and it is just no way that this anal cerclage will lead to any benefit for the patient. So for full thickness rectal prolapse, if the patient's reserves, physiologic reserves are poor, you choose transanal procedures. It is the least invasive. I'm talking at AMASI, the minimal access surgeons. This is the most minimal access procedure because it is transanal. It is called in the textbooks. Unfortunately, the name perineal had stuck to it, but it should be changed to transanal procedure. It is extremely well tolerated. Recurrence rate of 8 to 10% is considered acceptable. Repeat surgery is quite easy and feasible as well. Abdominal procedures overall will have lower recurrence rates, better functional outcomes, and the minimally access surgery gives excellent cosmetic results. If we talk about now transanal procedures, the 2 main are Delorme and Altmaier. Delorme is just mucosectomy. Altmaier is full thickness perineal proctosigmoidectomy. As you saw, although I was trained in my fellowship in Orlando to do Delorme's procedures, I saw what a bloody procedure it was, and it is not physiologic according to my personal opinion. I never felt comfortable doing a single Delorme or recommending it to a patient. All of my surgeries were Altmaier's. However, if you are trained, I would be respectful and say, do what you have been trained to do. These are again photos that are from my book chapter, and it's a very simple, straightforward procedure for patients who present with strangulated rectal prolapse. In fact, one of these patients was at BKL Walla Hospital in Chiplun, and it so happened, for patient's luck, that I was there on the day he came during these visits, and I was able to do the procedure. The key here is to find the anterior cul-de-sac. You make the incision about a centimeter distal to the dentate line, and then you go all the way around. What I have found is that the Lone Star retractor that we have shown here is of critical importance. It makes life really easy. Having a ligature makes life really easy. Regarding the anastomosis, Dr. Sergio Larache, my mentor, my teacher in Orlando, he taught me how to do a hands-on anastomosis. It is very simple, straightforward, no cost of the stapler. I know Dr. Roy Patenkar has a very nice article that he has published about stapled anastomosis. Yes, it is one option. There are many options. But there is a lot of mismatch between the diameter of the sigmoid and the diameter of the anal canal that you are going to do this coloanal anastomosis. So by making a oblique cut and then in a segment by segment, sector by sector, a wonderful hands-on anastomosis can be done. The proof of the pudding is in eating it. If the standard principles of preserving the blood supply and avoiding tension is maintained, the incidence of anastomotic leaks here is minimal. In my hands, there was one pelvic abscess, which might have been a contained leak, but it gives excellent outcomes. This is the pre and the post-operative views. Now when we come, let us talk about the abdominal procedures. And here, when we choose, if a patient comes capable of handling the stress of laparoscopic surgery, that's the approach. Open, minimally invasive. You will be amazed to hear in US, many surgeons are still doing open surgery. What procedure you would do? Rectopexy alone. There is a trend towards rectopexy, or you add resection rectopexy. And depending on the detail, you use mesh or you do not use mesh. The important thing to understand is that these traditional fundamental principles have evolved. And then I'm obviously going to talk about issues. So just give me a minute or so. But complete posterior mobilization of the rectum from promontory to the levatus. Fix the rectum using either lateral ligaments or a mesh to the sacrum. The mesh is fixed to the sacrum and wrapped around, and it is fixed to the rectum, leaving an anterior strip of the rectum uncovered. So as I said, approach depends on surgeon's training and availability. Rectopexy, as I described, optionally you add levatorplasty, and optionally you add rectosigmoid resection rectopexy. Now, is there any evidence base to any of these things? Yes. The Association of Colon and Rectal Surgeons, they publish clinical practice guidelines depending on when substantial new evidence accumulates. So although this is 6 years dated, the key here to realize is that by itself, it used to be taught. Yeah, some of us will remember that it used to be taught that all you need to do is complete posterior mobilization, and then you don't need to do anything. No, the 8 times recurrences have been reported if you were to just do that. And these are based on randomized controlled trials that have been reported in the literature. So by itself, this is inadequate. It is important to fix the rectum using either lateral ligaments or the mesh. And this is the key element. As far as the repair of pelvic floor and resection anastomosis, ASCRS, there is lack of proper availability of data. They leave it to surgeon's judgment as well. So what are the major disadvantages of this US-centric mesh rectopexy, which is posterior dissection? Quality of life issues, erectile dysfunction, micturition dysfunction, retrograde ejaculation or anejaculation, the dry orgasm as is described. The incidence is up to 20% as reported by Yakut. Why is that? That is because of the posterior dissection. And the question that is asked is, in a benign condition, is up to 20% complication rate of these quality of life issues justifiable? Now, this is the question in my mind that I've put forth. Are these surgeons respecting the anatomy? Are these surgeons doing a sharp dissection? Are they visualizing the pelvic nerves? Even for rectal cancer, even after neoadjuvant chemoradiation therapy, the TME, nerve-preserving TME, you don't have 20% incidence of these quality of life issues. So I think the improved visualization with the modern laparoscopy, the training, doing sharp dissection, this particular complication rate could be reduced. However, while this is to be well accepted, on the European side, the anterior mesh rectopexy has developed really well. In fact, the the European data tells us that the posterior dissection that requires meticulous technique can be safely omitted. This is not a new procedure. It has been first described as the OR procedure in 1984, modified by De Boer as a laparoscopic procedure described in 2004. Obviously, laparoscopic and robotic approaches have been described. So this is the anterior rectopexy or ventral rectopexy, as the question was. And the biggest advantage is that there is no dissection in the posterior posterior to the rectum in the presacral fascia. Dissection is only done anteriorly in the rectovaginal septum. It preserves the autonomic innervation. There is a single mesh that is anchored to the sacral promontory and to the anterior wall of the lower rectum. If there is a middle compartment prolapse, add sacrocolpopexy. If there is a rectocele and enterocele, it can be repaired concomitantly. So the ideal indications are not yet fully clear, but what seems to work is that it is best for primary repair and not for recurrent prolapse. And patients who are the patients who are best suited? Patients with relatively strong pelvic floor. It is best avoided if there is a higher Cleveland Clinic incontinence score and if patients have prolonged pudendal nerve terminal motor latency. This is a schematic diagram of the ventral rectopexy where the mesh is secured to the sacral promontory, brought down in two limbs, Y-like, and then it is sutured to the anterior wall of the rectum. Please note that you have to do a lot of dissection, take that deep cul-de-sac out, and then only this procedure will work. Excellent outcomes, as I said, have been reported by the systematic review, 17 studies. So we have a large number of patients. For the sake of time, I will go through here. Urinary complications are still most common, and mesh-related complications can occur, but it is roughly around 1% or so. Of note is that the recurrence rates, I mean, they say short term, but even 3-year and 5-year would be considered as a fairly long-term review follow-up. So even 10-year data shows that the recurrence rates are around 14%, which is considered acceptable for this type of procedure. The functional outcomes are durable. 80% had improvement in the associated obstructed defecation symptoms. 64% of patients had improvement in fecal incontinence. So I have put a top-level summary now because this is AMASI. I have used this particular term, minimal access, and again, I am highlighting that transanal is the most minimal access that you can do. There are no external scars whatsoever. My personal preference is perineal, or again, we are slaves of our training. Transanal proctosigmoidectomy, I always preferred hands-on coloanal. The abdominal, do a laparoscopic or robotic rectopexy. If you have been trained to do it, is not too hard to do. Although I have not done ventral rectopexies, the ventral rectopexy concepts are pretty simple, straightforward, and good dissection skills in the pelvis are needed. So that's the top-level summary. Now, is this all? Where do we go next? Innovation has no limits. I don't know how many of you are aware about this, but this is noted procedure. Now, this is where I'm going to talk. There are only 8 or 10 slides left, mainly to show the power of collaboration. Since the last 5 years, since I started coming to India more frequently, I came across Dr. Abhijit Chandra. We have become really good friends. He is the professor and head of the Department of Surgical Gastroenterology. Many of you know him. I had requested him to be there in attendance today, but he has a liver transplant to do. So he had invited me to conduct a symposium seminar on advanced minimally invasive laparoscopic and surgery, colorectal surgery at King George Medical University, Lucknow. I think it was 2018. And during that time, we developed, this young man. I was very impressed by his surgical skills. And we became good friends. He described to me a concept that he wanted to work upon and whether it will work. And this itself could be a one whole talk, but I want to go through the next few slides and describe that I started doing this collaborative work with him. And he has had tremendous success. Number of articles, his original article was in the Indian Journal of Gastroenterology 2019, but there was no success with publication in the diseases of the colon and rectum. He really wanted to have international attention. But the colorectal surgeons in the US just could not see the point. They were so completely confused as to who is writing this, what is to be done, so that's through that collaboration with multiple phone calls and WhatsApp phone calls, emails, and this and that, we successfully came out, and there's a substantial data that has been published now. This is basically endosonographic as well as transanal third space endoscopy. Basically, it consists of a ventral suture rectopexy where an ultrasound expert, and there is some special equipment. I don't have the time to show the video. And then posteriorly, a third space endoscopy is done by making an incision on the, this is under vision, and you create a tunnel, submucosal tunnel, and then you do a deep tack fixation to the sacral promontory. And the data is, only 14 patients. There are some more patients that have accrued, but basically what we have shown is that it is possible, it is feasible. Some patients a couple of patients had retrorectal abscess, which subsided with antibiotics, fever, subcutaneous erythema. We have overcome that. One patient developed early recurrence. So the procedure has been taught. I have personally seen his fellows who he has trained, and that it is certainly easy to learn. It is minimally invasive. It can be done under max sedation, avoids general anesthesia, safe and has low morbidity. There are definitely limitations. You have to have third endoscopic skills. You need a skilled ultrasound radiologist, intraoperative guidance. And right now it is a single center small series with only a short follow-up. A lot of interest has been generated in the US, but I don't think anybody else has followed up. It does need validation in the larger cohort with a longer follow-up, and the posterior fixation requires advanced endoscopic skills as well as some specialized equipment. So for conclusion, these are the advantages of this particular procedure. And since I'm at Amasi, what I would again like to point out is that an endoluminal is the most minimally invasive or the least invasive procedure. If endoluminal robots are available, it will the expansion of this in surgical hands will enhance. Do you need the TAMIS and things like that? No, you don't need TAMIS for this, but an endoscope itself is adequate. Thank you. That is the end of my presentation, and I don't know whether the questions and answers are now or later.
We'll have them at the end, sir, after all 4
Okay, perfect. I'm not able to see anybody else. How do I stop sharing? Or here? Oh, good. Thank you, sir.
Thank you, Dr. Patamke, for excellent talk and thought-provoking ideas for the future.
Thank you, sir.
We are ready to welcome you at Akarsi in Indore.
Indore, yes, I'm very excited. Never been to Indore first.
Now I invite Dr. Vikal Gindre to please invite the next speaker.
Thank you, Dr. Thank you, Rajiv, sir, for giving. And I would like to thank Amasi for giving me this opportunity to moderate this session today. And I would like to introduce Dr. Surendra Kumar Monto. He is currently a consultant surgeon in the Department of General Surgery. at Kru Tek Wat Hospital, Singapore. He completed a Minister of Health sponsored fellowship in pelvic floor and functional colorectal disorders in France in 2011, and he is pursuing his subspecialty interest in functional colorectal disorders. He has published books and has publications in several peer-reviewed journals as well. And he'll be speaking today on pelvic floor dysfunction.
Thank you, Dr. Bikal. I hope you can hear me all. And let me share my screen. Please let me know if you can see my screen.
Yes, sir. We can see the screen and we can hear you well. No issues.
All right. Thank you very much. First of all, thank you, Amasi, and in particular, Dr. Roy, for this kind invitation. And these are my credentials, and I've been asked to cover a very broad topic, which is approach to pelvic floor dysfunction. And I hope I can do justice to this topic in a span of 20 minutes. Now, this is the outline of what I will cover in my topic. I will cover what is pelvic floor, what is pelvic floor dysfunction or disorder, how do we clinically assess pelvic floor disorders, and what are the radiological investigations for pelvic floor disorders. And I'll be covering management of some common pelvic floor disorders. Rectal prolapse has been covered very well by Dr. Patankar, so I will skip it. And at the end, there will be a take-home message. Now, pelvic floor, you all know, is primarily made up of thick skeletal muscle, along with the nearby ligaments and investing fascia, which is the endopelvic fascia. And the main function is it allows passage and closure of urethra, vagina, and anus in males and females. It is divided into 3 compartments, anterior, middle, and posterior. But as we know that it works as a single functional unit. So which means if there is a disorder in one of the pelvic floor compartments, it is likely that the person or the patient may have disorder in the remaining 2 or other compartment in a male. Now, in order to understand the pelvic floor disorders, it is important that we understand some of the key anatomical facts. And here I have listed some of them. Mainly, it is made up of 2 muscles, which is the coccygeus and the levator ani muscles, which we are very familiar with. And levator ani is made up of 3 parts: iliococcygeus, puborectalis, and pubococcygeus. I will not go into the details of the attachments. We need to know about the blood supply and the innervation if we want to do a good clinical examination for pelvic floor disorders. There are some subtle differences between the male and female pelvis. Male is divided into 2 compartments and female pelvis is divided into 3 compartments. And we know that pelvic floor disorders are very common in females and are not so common in males. Now, what is pelvic floor dysfunction? Primarily, the dysfunction is either there may be a hyper or hypotonicity of the pelvic floor muscles, which can lead to either inability or difficulty to relax, or inability to or difficulty to contract, or inability to coordinate the movements of the pelvic floor. So a patient may have either one or a combination of all, these factors. And when any of these happens, this contributes to what is known as pelvic floor disorders. And we categorize the pelvic floor disorders into 5 broad categories, which are namely the prolapse disorders, the continence disorders, pelvic floor dyssynergia, and we all know obstructed defecation, myofascial pelvic pain, and sexual pain or dysfunction. For a colorectal surgeon, the common disorders which we encounter in our practice are mainly the prolapse disorders like rectocele, interception, enterocele, and sometimes in patients, they may have also cystocele or uterine prolapse. In terms of continence disorders, we mainly deal with the fecal incontinence, but some of these patients may also have urinary incontinence, what we call double continence, incontinence. So we may see these patients. And in terms of pelvic floor dyssynergy, obstructive defecation is a very common disorder as colorectal surgeons we encounter with. Now, approaching pelvic floor dysfunction is just like any other medical disorder. You need to have a plan in the mind, and it all starts with good history taking. Because if you do not take a good history, you cannot examine and you cannot proceed further in managing these patients. There's a saying that what mind doesn't know, eyes can't see. So I wouldn't emphasize more on a good history taking. Following that, we need to do a good physical examination. And in pelvic floor dysfunction, it's important to score the severity of the symptoms. And there are certain reasons for that, which I will discuss further. We need to, ask for appropriate investigations. And finally, we manage patients in a multidisciplinary manner. Now, the main focus of the clinical history is to rule out infection and or any life-threatening illnesses before we proceed to assess the pelvic floor disorders like cancers. It's important because colorectal cancers are very common. It's important to do the necessary investigations like colonoscopy or scans to rule out them. And then we review the symptoms and their severity. The main aims of taking a good history is to identify certain risk factors, as have been shown here, which could be mechanical, somatic, visceral, or even psychological. And if we are very clear about the risk factors, it's easy to order the necessary investigations as well as examine the relevant parts. Now, for physical examination, the main aim is to do an external as well as an internal examination of vagina and anorectum, if you want to examine the whole pelvic floor. And just like any examination, like an abdominal examination, there are certain steps which should not be omitted. We always start with inspection, like in abdominal examination, we start with an inspection, and the inspection is mainly of the external genitalia. This is followed by palpation of the muscles and the bony elements of the perineum, which can give us some valuable information. And then there are two additional steps which are very important: checking the sensation of the area and assessment of the muscles for tonicity and strength, because that can tell you about the severity as well as the type of the pelvic floor disorder the patient has. Now, some of the key points on physical examination. This is a very good picture. If you look at it carefully, you need to do with an index finger. Like we are very familiar with doing a digital rectal examination, but this is slightly different because you need to do a superficial as well as a deep palpation by putting the finger, you may put first in vagina and then in the anorectum. And you need to assess for any myofascial pain, any trigger points, any taut bands of muscles, and identify the general tonicity of the muscles. That will tell you what is the status of the pelvic floor. Now, strength evaluation of pelvic floor muscles is actually very simple. Just by asking the patient to lift and see the lift and the descent of the perineal body. Just by looking at it, you can ask the patient to squeeze as if the patient wants to control the motion. You can see the contraction and the relaxation of the pelvic floor. And by putting in the finger in the vagina or the anorectum, you can check for the endurance of the squeeze. So it's important to check the anal squeeze, what we commonly know. And similarly, sensory testing by simply using a cotton swab or a pinprick sensation can tell us whether the patient has any neurological cause for pelvic floor disorders. So these are some of the key points which you must remember when you are examining a patient with pelvic floor disorders. Now, after examination and taking history, we need to do the severity scoring. And it's important first to know the baseline of the severity. And it's also important to document, because if you want to convey it to a colleague or a different, you can tell in terms of severity that this patient is mild, moderate, or severe, or in terms of actual scores. Secondly, it's important to follow up the patient. If you are offering a treatment, then you can see whether your treatment is successful or not. And thirdly, if there is a failure of treatment, then again, you can know by your scoring whether your treatment is good or it has failed. But the problem is there are multiple scoring systems, as I seen here. For fecal incontinence, we have at least 4 or 5. I've listed only 2 here. Similarly, for constipation, there are multiple. I've listed only 2. And similarly, for the prolapse disorders, there are also multiple, but the one universally acceptable is this POPQ system, which I have listed here. Now, there are multiple scoring systems, and sometimes it is confusing which ones to use. And fortunately, there was an international consensus in 2019, and an expert panel agreed on a battery of instruments, and they call it IMPACT. It stands for Initial Measurement of Patient-Reported Complaints Tool. And it is basically comprising of a short form and a long form with 45 questions for women and 34 questions for men in the short form. And in a longer version, which has got about 85 to 94 questions, which can further elaborate on the disorder in a patient. And there has been a wide acceptance by multiple societies. So if you want to know the more details about this IMPACT, this is the paper in which it was published. And the final list of instruments which have been recommended for inclusion into the IMPACT tool are shown on the right-hand side in the table for fecal incontinence, constipation, urinary incontinence, pelvic organ prolapse, as well as sexual function. And the beauty of this tool is that it has been shown to be useful regardless of the type of specialist you are, whether you are a colorectal surgeon, you're a urogynecologist, you're a urologist, gastroenterologist. So there is some uniformity by using this IMPACT tool, and it makes it easier, especially when you are managing these patients in a multidisciplinary board or treatment panel. Now, in terms of radiological assessment, I will briefly discuss it because I know there is a lecture on radiology. One of the important principles to remember is that pelvic floor disorders rarely occur in isolation. That means if the patient has a disorder of one compartment, say posterior compartment, usually they will have a disorder in the middle or the anterior compartment as well. And in order of my preference, the investigations which I order for my patients is magnetic resonance proctography, mainly the dynamic MRI, endoanal ultrasound, defecation proctography if it is an isolated posterior compartment problem. And sometimes we order some other tests like manometry or PNT, ML, and others. Now, again, the choice between these techniques is dependent on the availability of the equipment and local expertise. But if you really want to do one investigation which can assess the whole pelvic floor, that is dynamic MR. As you can see, some of the key highlights of the different radiological investigations. You can see MR defecography easily scores over others. But if you are evaluating just the posterior compartment, I think defecography with some contrast, it can do justice and can help in the diagnosis of a disorder. Now, the advantage of the dynamic MR is that it not only shows you the viscera, but it also shows you the soft tissue. Sometimes there is a problem with the soft tissue, especially the ligaments and the fascia, which can lead to the prolapse disorder. So MRI is very important and very useful investigation in those patients. Now, coming to the management of pelvic floor disorders, I have put up this in very bold, that anatomical severity, which can be assessed either on clinical examination or imaging, is not equivalent to clinical or symptomatic severity. I would like to explain it. That means if a patient, sometimes you see a patient who has got a severe, anatomical deformities seen on imaging or clinical examination, but they may be having minimal symptoms. So you should not be operating on those patients. And similarly, if the patient, you can see a patient who has got severe symptoms, but the anatomy, clinical examination or the imaging may not show any anatomical abnormality, then you must be very careful in offering surgery to these patients, because you may be missing some cause which may be actually causing the symptoms and not the anatomical abnormality which you are seeing. So it's a bit of paradox in managing pelvic floor disorders. And again, I want to emphasize on this point that pelvic floor disorders do not occur in isolation or rarely occur in isolation. So that means if you fix a problem in posterior compartment, a patient, the covert problem in middle or the anterior compartment may become overt after the management. So if a patient comes with fecal incontinence or prolapse, you fix it, and patient may again come back to you with a urinary incontinence because it was overlooked in the initial assessment, and you only fix the posterior compartment. So you have to be very careful in that aspect. Now, we always start management of pelvic floor disorders in a stepwise manner. We never offer patients surgery or surgical intervention in the beginning. We always start with some lifestyle changes, which are easy to do. And you gain some confidence and you gain some trust with the patient during that time. Simple dietary changes, losing weight may help. There are multiple non-surgical management options like bladder and bowel training, pelvic floor muscle training, biofeedback. I'm sure there is a lecture on that. And simple medications like for fecal incontinence, we can give antidiarrheals. For constipation or obstructive defecation, we can give laxatives. And surgical management has to be carefully chosen and depends on the diagnosis and whether it's an isolated diagnosis or a combination of other problems in the pelvic floor. Now, it's important that these patients are discussed in a multidisciplinary team MDT because you can get opinions from other specialists, especially if it is a generalized pelvic floor disorder. So the trend is managing these patients in a MDT and not in isolation. And there is a reason for that, because there are multiple options available for managing pelvic floor disorders. And if we broadly categorize them into two groups, the one group provides the surgical correction like sphincter repairs, artificial sphincters, graciloplasties, stars, and rectopexies. And the other group provides physiological correction like sacral nerve stimulation and PTNS. But it's very hard to decide which operation to offer or which surgical intervention to offer to an individual patient. Now, as an example, this is a classical example like surgical management of ODS. As you can see, there are multiple options available, both perineal as well as abdominal. Perineal because you have transanal, transvaginal, as well as transperineal. The ones in the red are more commonly used, and I will show you some of the pictures and what is the evidence. Now, when you have multiple options, and especially in pelvic floor disorders where we don't have a grade 1 evidence, the next best thing is to review the best available literature and arrive at a consensus. So thankfully, a European consensus was published 2 years back. This is a very busy slide, but it is a very important slide on managing ODS. And they take into consideration two things when managing ODS. One is the anal sphincter function, and the second is the pelvic floor function. Now, based on these, you can divide patients into 4 groups. One who have purely pelvic floor dyssynergia, that means paradoxical pivorectalis. These patients should be managed by biofeedback. No surgical intervention should be offered. And there was a full agreement. The red box means a full agreement among the experts. Now, when you have a patient with pelvic floor dyssynergia and anatomical abnormalities, as shown in the blue boxes, you again start with biofeedback. And if the patient has normal function, then you can explore the surgical options. If patient has normal pelvic floor, and then depending on the anal sphincter function, you can offer accordingly the. Now, if you look at this chart, you can see the red boxes. In Europe, especially laparoscopic ventral rectopexy is gaining popularity and is considered to be a surgical option of choice. And STAR right now is not a surgical option of choice, but it should be offered in very, very select patients. Just to show some pictures, two typical steps of STAR: the anterior stapling, where you take sutures at 3, 12, and 9 o'clock, and then the posterior stapling, and it allows you to resect the rectum in full thickness to correct certain disorders like rectocele or mucosal prolapse of the rectum. Now, this is a very short video, my video of ventral mesh rectopexy, as Dr. Patankar mentioned about it, and fortunately, I have a very short clip. It's about 3 minutes or so. So you start dissection at sacral promontory and dissect along the right border of the rectum in a J shape, and then you move towards the pouch of Douglas. As you can see, the pouch of Douglas in this patient is very deep. And you will be surprised that this is actually a male patient, who had a sigmoidocele as well as a rectocele. And after treating him conservatively for more than 6 months, he finally decided to go ahead for surgery, and we offered him a ventral mesh rectopexy. You can see the seminal vesicles. The anterior dissection has to be very deep, almost to the level of the prostate. And then you have to expose the levators on the both sides. Now, it's easier to do robotically, a bit challenging laparoscopically, but with training and with practice, we managed to do it. And then you fix a J-shaped mesh. This is a very old video. We have changed to biologic mesh currently. We no longer use the prosthetic mesh. And this mesh is like a hockey stick shape, where you have a horizontal limb which covers the rectum. There are surgeons who actually suture it to the rectum, but we actually suture it to the levators on both sides. And then we fix it to the sacral promontory. We hitch it up. It does not have to be very tight. It just has to lie in a relaxed manner along the right border of the rectum. And then we fix it with a suture to the promontory. And then finally, we will peritonealize the mesh. That means we will cover the mesh with the peritoneum so that there is no risk of bowel adhesions. And so far, based on our results and the published literature, it has given us good outcomes for the patients. Most patients go home on the same day in the evening or stay at the most for 1 day. And antroceles or sigmoidoceles are concomitantly treated as you make the pouch of Douglas very shallow. And so you don't need to do any rectopexies or sigmoidopexies for them. And that allows a good function, especially you do not worsen the constipation because there is no posterior dissection involved in this technique. So similarly, for treating fecal incontinence, we have multiple options. Again, it's not easy to decide which option to offer in this patient, but currently I would say that sacral nerve stimulation is becoming, in a way, gold standard or the first option to be offered, although in certain patients, we do offer anal sphincter repairs. So this is my personal algorithm for managing fecal incontinence. If it is normal anatomy, most of them, they have idiopathic fecal incontinence. Most of them will end up with biofeedback with some medications. If I find isolated sphincter defects, especially on an ultrasound, I still offer them some biofeedback or at least pelvic floor muscle training. And then I do offer them anal sphincter repairs, which gives them good relief for maybe 5-6 years. And we know that after over a long period of time, the effect of the repair wears off. But if it is a multifocal sphincter defect, then usually we offer them sacral nerve stimulation. I had some experience with magnetic anal sphincter when I was doing my fellowship in France, but we do not use it in Asia, especially in Singapore. I don't have any further experience on that besides that one in France. So currently we offer sacral nerve stimulation for patients with severe fecal incontinence. Now, there are certain challenges. This may be my second last slide. As I have shown, there are a spectrum of possible causes for pelvic floor dysfunction. And usually you may have more than one cause for clinical presentation in a patient. There is always a variability in presentation. Even patients with rectocele of same size, they present very, very differently. There are multiple techniques available for their management. And unfortunately, there is a lack of formal training. Very few people are actually interested in managing pelvic floor disorders. There is also a lack of resources, like sacral nerve stimulation is not readily available in many countries yet. There is variation in practice. And there's also lack of high quality evidence and guidelines. But fortunately, recent, at least expert consensus are coming up, which do help us in clinical management of these patients. And to conclude my talk, I would say that pelvic floor dysfunction is still a challenging clinical condition. Good clinical assessment supported by appropriate imaging is key to the correct diagnosis. No single treatment method is suitable for a single patient, so you need to make a tailor-made approach for every patient. Conservative management in most and surgery in the least. Multidisciplinary management is the preferred approach, and we need to invest in further training, resources, and research in managing these patients better. And thank you very much for your patient listening. I hope I could do justice to this topic in a short span of time. Thank you very much. I'll stop sharing. If there are any questions, I would be happy to take.
We'll take questions at the end, sir, after all four speakers have spoken, because there'll be some overlap of questions. That's why it's better we take them at the end.
Okay, no problem. Thank you.
Dr. Butari, please.
Yes. For the next talk, I welcome Dr. Ravi Thapar, who is a consultant at the Jain Hospital, Mumbai. He will be speaking on imaging in pelvic floor disorder. He did his post-graduation in radiology from Nair Hospital, TNMC, Mumbai. He had special training in CT and MRI imaging and fellowship in advanced diagnostics, neuroimaging, and cardiac MRI from Asan Medical Center, Seoul, South Korea. Dr. Ravi Thapar, please.
Thank you, sir. Firstly, I'll thank all the organizers for giving me this opportunity, and I'll go directly to my topic. So is my screen share working well?
Yes.
Okay, so I'll be discussing imaging in obstructive defecation syndrome, and we all have in the previous talks referred to it. So it is basically characterized by the urge to defecate, but an impaired ability to expel that fecal bolus. So typically the patients have symptoms of unsuccessful fecal evacuation attempts, excessive straining, pain, bleeding after defecation, and a sense of incomplete evacuation. Also, many of these patients would give you a history of resorting to digital rectal evacuation. MR defecography is really the modality of choice as of now, and it helps to differentiate these patients into two distinct subsets. So first of all, it can divide the patients into those who do not have significant structural abnormalities. Now, once you identify this group of patients, these are better treated by conservative treatment approaches like diet and lifestyle modifications, and of course, biofeedback. The second subgroup of patients is those in which MR defecography identifies significant structural abnormalities, for which then appropriate surgical approaches or surgical management can be done depending upon those structural abnormalities. So this is where MR defecography comes right in the beginning in the evaluation of these patients with ODS. So initially, before MR defecography, we used to do conventional defecograms, and this is an example of a conventional defecogram where we used to give rectal jelly, and also we used to give oral barium to opacify the small bowel loops. And here you can see that is the anterior rectocele, the bulge of the anterior rectal wall. And here we can see along with the anterior rectocele, there is also an enterocele. But here, of course, you can make out that the limitations of the modality are very apparent. First of all, you are not looking at the soft tissue structures at all. We are just relying at the bony landmarks, and you are just not getting any information about the other compartments. We are only really looking at the posterior compartment. At this stage, I'll very briefly refer to the anatomy that we are looking at. So this is the pubic symphysis, that is the large coccygeal articulation. And this line here, that is the pubococcygeal line. That is a very important line because all the pelvic organ descents, they are measured as tangent distances below this PC line. Also, the other thing that is shown here is the anorectal angle, which is formed by the posterior wall of the rectum with the posterior wall of the anal canal. So since conventional difficography had a lot of limitations, we moved to MR difficography, and this is performed in a closed tunnel 1.5 Tesla magnet. And this is how the patient is placed in the magnet with the coil on the patient's tummy. And these are the kind of images we get now. So this is a typical cine loop of MR difficography. And now you can see that you are evaluating all the three compartments with exquisite soft tissue resolution. And the pathology just speaks for itself. You don't really have to really describe it. It just is very apparent and you can pick up the pathologies in a very elegant fashion. So what is the procedure really? First of all, no preparation whatsoever is required. We do a per rectal installation of ultrasound jelly, which is readily available in any radiology department. Before we start with the dynamic, we do a routine T2 anatomic sequences of the pelvis so that we are sure we are not missing some other pathology like a pelvic mass or something else. And that ensures that you have a good FOV and you cover all the pelvis. And then we move to the heart of the MR difficography, the dynamic or the cine sequence. Now, when this sequence is going on, the patient is asked to do certain maneuvers. First, the patient is at rest. Then we ask the patient to squeeze the pelvic floor inwards, like you do when you do not want to pass the stool. So this is where we ask the patient to actually contract the pelvic muscles inwards and try to close the anal sphincters. Then we ask the patient to give short straining efforts. So he gives a short straining effort and relaxes, again strains and relaxes. So this helps to show us the pelvic muscle tone and see the excursion of the pelvic floor. And lastly, we ask the patient to give a sustained straining effort, release the anal sphincters and actually pass out the rectal jelly. So what happens normally? We have to know the normal physiology before we start looking at the pathology. So normally, this is how it looks at rest. So that is the anorectal angle at rest. Then when the patient squeezes the pelvic floor inwards, there is actually elevation of the pelvic floor and the anorectal angle becomes even more acute. So that is the squeeze maneuver. When the patient gives the straining maneuver, there is a normal physiologic descent of the pelvic floor. And because of that, the anorectal angle, you can see it has opened up wide and become obtuse. And the rectum and the anal canal are now almost aligned in a straight line. And after this, when he gives a sustained straining effort and relaxes the anal sphincters, you can actually see the jelly being passed out. This black line I've already referred to, that is the pubococcygeal line. And this red line is actually the M line, which is basically the tangent distance of the anorectal junction below the PC line. And this pink line is the H line, which actually is the size of the hiatus. It goes from the pubic symphysis to the anorectal junction, the posterior wall of the anorectal junction. So now I'll show you some pathologies depicted on the MR difficography. So this is the first case. And you can see as the patient strains, you see that bulge of the anterior rectal wall. So that is the anterior rectocele. So you can expect what happens is that as the patient defecates, the fecal contents, they get retained within this rectocele. And as a result of that, he will get a feeling of incomplete rectal evacuation. And he may also resort to maneuvers. So one of the things they do is they put the finger in the rectum and try to evacuate that rectocele. In case of females, they may put the finger in the vagina and press the posterior wall of the vagina to sort of empty out this rectocele. Now, all rectoceles are not clinically significant. A rectocele which is more than 2 centimeters in length and which shows the presence of retained contents at the end of defecation, they are likely to be clinically significant. The rectoceles are classified as mild, moderate, severe, depending upon their length. So the length is measured from the expected normal anterior contour to the actual anterior contour. So this is the length. So 0 to 2 centimeters will be a mild rectocele, 2 to 4 centimeters will be a moderate rectocele, and more than 4 centimeters will be a large rectocele. So a moderate or a large rectocele which shows retained contents at end of defecation is the one which is likely to be clinically significant. Now, looking at the next case, so this is a patient, as he strains, you see that telescoping of the rectum into itself. So this is a classical recto-rectal intussusception. So we get that arrowhead configuration when the intussusception occurs. That is the arrowhead configuration, and this is a classical recto-rectal or recto-anal intussusception, which is seen on the MR difficogram. Now, this is a further extension of the same process as Dr. Patankar referred to. So you see that it starts with the intussusception, and then as the patient continues to strain, there is a full thickness prolapse of the rectum through the anal wall. So that is a complete rectal prolapse, which also will be evident clinically. So this is the example of a full thickness prolapse of the rectum coming out through the anal verge. Now, this is a case which shows pathologies in the other compartments as well. So as the patient strains, you see the rectocele, very minimal intussusception, but also there is descent of the vault and the bladder. So this soft tissue between the urinary bladder and the rectum, that is the vaginal vault. So these are the static images, and you can see that's how we measure the distances below the PC line. And there is a descent of the vault as well as the urinary bladder. So this patient underwent AP repair with sacrospinous fixation with transobturator tape, and this is the post-op MR difficography. And now you can see the rectocele is no longer there. The bladder and the vault are staying put where they should be. So MR imaging wise, there is a definite improvement in the appearance, and clinically also the patient showed good symptomatic improvement. So these are the post-operative static images. This is a different kind of pathology again, which was also elucidated in the other talks before. So here what you see is that as the patient starts with the straining, you see a very prominent bulge of the puborectalis on the posterior wall. So even during the defecation, the anorectal angle is remaining acute. So this is basically a very hyperactive puborectalis, which is causing a persistent and acute anorectal angle during defecation, a persistent indentation on the posterior wall of the anorectal junction. And this is also known as the hyperactive puborectalis syndrome or the spastic perineum syndrome. And some surgeons have attempted to treat this by injecting botulinum toxin into this hyperactive puborectalis to try and weaken the muscle a little. But obviously, it's a tight rope walk between that and incontinence. This is again an important pathology which can be picked up. And so you see what happens here as the patient starts with the straining. There is the intussusception, there is that rectocele, but more importantly, these are the small bowel loops which have come down into the pouch of Douglas way below the PC line. So that is an enterocele. Now, this is an important finding to be told to the surgeon if he's attempting a star, because during the stapler firing, these small bowel loops which are closely abutting the anterior wall of the rectum, they may get trapped in the stapler and may result in a small bowel perforation. So this is an important finding which we have to warn our surgical colleagues about when we do the pre-op MR difficogram. So that is the enterocele. You can see these are the small bowel loops. That is the rectocele. Sometimes we also instill dye ultrasound jelly into the vagina to give a 3-compartmental difficogram. Although even in the routine MR difficos, you see all the 3 compartments quite well. And here you see a massive descent of all the 3 compartments. So this is a very poor global pelvic floor tone, resulting in a descent of all the 3 compartments. So that is basically known as also the descending perineum syndrome. So we see that is the PC line, and those are the descents of all the 3 compartments. The descents are classified as mild, moderate, severe. 0 to 3 centimeters is mild, which is almost physiological, that is normal. 3 to 6 centimeters is moderate, and more than 6 centimeters is a severe pelvic floor descent. So this is a very difficult patient to treat because there is a global pelvic floor weakness, and that is very difficult to manage. So considering MR difficography, the pros are it has an excellent soft tissue resolution. There is no radiation whatsoever, so you can repeat it pre and post-op without any worries about the radiation. It is multiplanar and dynamic. The cons availability, not all centers do it, but recently there is a trend towards more and more centers taking up MR difficograms. And the supine position. So regarding the supine position, initially there was a lot of debate whether the MRD in the supine position, which is non-physiologic, will replicate the findings. But there was a good article in Radiographics which compared supine versus erect difficograms, and it found that even in the supine position, if the patient gives adequate straining effort, then all the clinically significant pathologies will get elicited. So they found no statistically significant difference between supine and erect difficograms. The caveat being that the patient should be able to give a good straining effort. So for that, we do certain tips and tricks. We sort of give the patient a little bit of hip flexion and knee flexion, maybe with a pad under the heel, against which the patient can leverage and apply a good straining effort. So once the straining effort is good, the supine difficogram will do its job. This was the article that we have published in the Indian Journal of Radiology and Imaging on MR difficograms. I'll very briefly refer to the one other test that we do for these patients of ODS and chronic constipation and other pelvic floor dysfunction. So this is a colonic transit study where we give the lead pellets to the patient and we take serial X-rays every 12 hours. The important thing is before we give the pellets, we ensure that from the last 5 to 7 days, no motility drugs are given to the patient because we want to evaluate the native bowel motility of the patient. So if at the end of 48 hours, we still find a lot of lead pellets clustering in the abdomen, that is a sign of motility issue or colonic inertia. So if they all are clustered in the right colon, that would refer to a right colonic inertia. If they all are clustered in the left colon like this, that would be a left colonic inertia. And if they all are clustered in the pelvis, this could either mean a sigmoid colonic motility issue, or it could refer to ODS because the feces are coming till the sigmoid and rectum, but then the patient is not able to evacuate them. I'd like to thank my colleagues, Dr. Ritesh and Dr. Vipul and Dr. Roy Patankar sir for their help in this endeavor. And thank you to the organizers again.
Excellent talk, Dr. Ravi. It was very crisp with their very clear messages. And most of this time as a surgeon, most of the surgeons find difficulty in reading the MR. You made it easy today.
Thank you, sir.
Explain the indication and plus you explained correlated with the clinical symptoms and clinical outcomes and indications for surgery. Thank you very much. Thank you very much.
Thank you, sir.
Dr. Mikkel.
I would like to introduce Dr. Archana Rege. She's a physiotherapist with more than 15 years experience in handling orthopedic, neurological, surgical, and pediatric cases at clinical and hospital setups. Currently, she's at Jain Hospital, Mumbai, and she'll be discussing on biofeedback for pelvic floor dysfunction. Over to you, Dr. Archana Rege.
Yeah, thank you, sir. Thank you for the introduction. I'll just share my screen. So is it visible?
Yes, Dr. It's visible.
Yeah. Good evening, everybody. I'm Archana Rege, physiotherapist. So I'm a certified pelvic floor rehabilitation specialist, and I'm going to talk on biofeedback and pelvic floor rehabilitation today. So biofeedback or pelvic floor rehabilitation, generally we divide it into two parts. One is biofeedback with exercises and diet modification, and another one is EMG biofeedback. So in biofeedback exercises, we generally have modified Kegels, active pelvic floor exercises, relaxation techniques, which include yoga asanas and soft tissue mobilization techniques. So after a thorough physiotherapy assessment that we do on the patients, we come to a conclusion regarding their pelvic floor, what kind of muscle dysfunction they would be having. So generally, we divide the pelvic floor muscle dysfunctions into three types. One is a hypertonic pelvic floor muscle dysfunction, where the patient is not able to completely relax the overactive, tight, or the spasmodic muscles. So this generally is seen in cases like pudendal neuralgia, puborectalis syndrome, ODS cases, Lewy-Tenney syndrome, or proctalgia fugax. Second is hypotonic pelvic floor muscle dysfunction, where the patient is not able to contract strongly, especially when needed. So these pelvic floor muscles are weak or lax. And this is most commonly seen in, again, ODS cases, chronic constipation, post-surgical cases, etc. Then we have this incoordination pelvic floor muscle dysfunction. So where the patient is not able to create a proper sequencing of pelvic floor muscle contraction and relaxation. This is also known as pelvic floor dyssynergia. So treatment strategies, we have different treatment protocols for different dysfunctions. So example, like if we have hypertonic dysfunction where the muscles are lax or weak, we generally can give Kegels exercises where emphasis is more on contraction and the whole time than the relaxation time. This includes quick contraction and more repetition. But in cases of pelvic organ prolapse, we give modified Kegel's exercise where we keep a balance between the hold time as well as the relaxation time. Then we have active pelvic floor exercises where we incorporate other movements along with pelvic floor contraction. This again emphasizes more on contraction as well as the relaxation time, equal emphasis on contraction and relaxation time. Again, we also encourage the patients to use these exercises in their activities of daily living. And also a lot of active pelvic floor exercises can be done using per vaginal or per rectal techniques where we can individually strengthen the particular muscles. So these are few images of how we do it. So how we are incorporating our basic exercises in along with the pelvic floor. Also how to accommodate them in your day-to-day activities, as most of them are office-going patients. So how we can make them do the exercises within their office premises also. Second is the hypertonic dysfunction. Here, basically, the patient comes with the symptoms of pain, tightness, muscle, pelvic floor muscle spasm. So first, the aim is to get the pain down and then start with the exercises. So to relieve the pain, we can use cryotherapy, cold packs, heat therapy in the form of sitz bath or hot water or fermentation, and ultrasonic therapy. So in such cases, generally we start with yoga asanas or pelvic floor stretching and relaxation exercises, where we can give deep breathing and diaphragmatic exercises, and a lot of yoga asanas like Malasan, Balanandasan, Balasan, Mandukasan, and piriformis hamstring stretch, also the other pelvic floor muscle stretch. So these are the few examples of stretches that we generally recommend. Now, another, as we already spoke, biofeedback therapy consists of biofeedback exercises as well as EMG biofeedback. It is used to strengthen the weak pelvic floor muscle, also helps us to relax the tight and shortened pelvic floor muscles. So it is a treatment which gives the feedback in the form of visual, auditory, or tactile inputs. So we'll now discuss EMG biofeedback. So EMG biofeedback is a method of retraining the muscles by creating new feedback systems as a result of conversion of myoelectric signals in muscles into visual and auditory signals. So it is in the form of graphical representation, which can give us a brief idea of the type of muscle dysfunction as we discussed, whether it is hypotonic, hypertonic, or it has dyssynergia. It also helps an individual to gain voluntary control using the device as it produces auditory as well as visual stimulus. It gives an objective documentation, gives a baseline for evaluation, and easier to plan treatment strategies as once we know what the muscle dysfunction is. Again, the frequency varies from patient to patient, but generally it is once in a week for 3 weeks, and then we call up for follow-ups after every 3 or 6 months, depending on the case. Duration generally is 30 to 40 minutes, and treatment is given in the form of activities where there are visual and auditory games, which are more entertaining for the patients also and encourages them to do. So I'll just show a short video how this EMG biofeedback that we have, it works. So this is the machine which is connected. Oh, I'm sorry. So this is the machine which is connected to the laptop via software. And once we evaluate the patient, once we assess the patient, we come to know regarding their, oh, I'm so sorry. So then we have these different activities in the form of games, which is more encouraging for the patients. Oh, I'm so sorry, it is not pausing. Okay. So once we get an once we assess the patient, we know its upper limit as well as the lower limit. So these limits are set by the physiotherapist. And then I encourage the patient to do these activities. So when the patient contracts the pelvic floor muscle strongly, it goes beyond the upper limit, the aeroplane will go up. And the same way, once the patient relaxes, the aeroplane will come down. This way we have multiple games, which are also entertaining for the patients, and they are encouraged to do more. So one of them is again a rose game. So this is very helpful in cases of dyssynergia where the patient is not able to relax completely. So here the values again are set of the upper limit and the lower limit. And once the patient relaxes completely, the rose opens up. Once he contracts the pelvic floor to the level that has been set by the therapist, the rose closes. So again, this has a timer. This has the number of times we do. So this is the patients are encouraged to do more in a lesser amount of time. So some EMG biofeedback cases I'll be discussing. So this is a case of a 34-year-old female patient diagnosed with ODS. Her MRI decocography showed moderate descent of anorectal junction, moderate anterior rectocele, and mild cystosis. So when she came to us, her modified Longo score was 21. And muscle strength, as we can see here, that I have here the average which is shown, and I've put it in a red box, is the muscle strength. So it is 5.2 microvolts. So post 4 months after a exercise protocol and the dietary modifications, when she came back to us, her strength was double of what it was prior. So now her strength, when she came back to us, was 17.7, and the Longo score was also 3. So it has shown, the patient had shown a drastic change in all her symptoms also. The same, another case that we had seen is a 58-year-old female who was diagnosed with ODS as well as pelvic floor muscle dyssynergia. Here her maximum muscle strength in maximum activation was 11.3 microvolts. And when she, when asked to relax, her relaxation was not up to the baseline. So it was 7.8 microvolts. And she came with a Longo score of 21. So after 8 months of rigorous training and all, her dyssynergia had improved a lot. So muscle strength had also improved, as well as her relaxation had also come down to a certain extent. Her modified Longo score also had showed an improvement. So other techniques beyond biofeedback that we use is a colon massage, soft tissue mobilization techniques, modalities like heat therapy, cryotherapy, ultrasound, electrical stimulation, core strengthening, postural training. So colon massage, this is one of the techniques that we use to help with the mobility of the colon. So especially in the ODS cases. So generally it is done with a sponge ball. So we started from the point A on the descending colon. So we first show the patient regarding the orientation of the colon, and then we start with the point A, and then we roll the ball with a little pressure. So it's a sponge ball, so it is more comfortable. Then we roll the ball with the pressure downwards, and then we get it down till the point B. So that way 3 repetitions on from A to B is done. And then we move towards C. So then from C, we again take, from C, we roll the ball up to A, and again the same pathway. So first, initially, we are clearing whatever fecal matter is in this area, and then we are going ahead so that there is a little more smoother movement that can happen. And then we are working on from D to C, C to A, and then B again 3 times. So each time that we are, each level that we are doing, each step that we are doing it 3 times. Another techniques that we use is internal mobilization techniques. So this can be used for strengthening purpose, as we can see here. So if we feel any particular muscle is weak, then according to the placement of the muscles, we also, we do it as a therapist, we do it on the patient, as well as train the patient to do it as a whole program. Also in cases of where there is puborectalis syndrome, of there is some trigger points which are there in the puborectalis, we generally do a soft tissue mobilization where we can release that trigger point by giving a deep kneading pressure. So there are few studies which have shown that the biofeedback has shown improvement when it is combined with diet. So there are few studies which have shown again efficacy of biofeedback plus trans-electric stimulation. Most of these studies were done with a exercise program, and very few studies are done with anal manometry or EMG biofeedback. Thank you, sir.
Thank you, Dr. Archana Reddy, for a very informative and elaborative presentation. It is really amazing to see how physiotherapy has evolved with a variety of exercises for different types of conditions. And it is amazing to see how biofeedback has evolved with time to be patient-friendly and in a game format, which might have better compliance for the patient. And even I was not aware of that. Thank you very much.
Thank you, sir. Thank you for inviting me.
So before we move on to the discussion, I request Dr. Devarshi for the next quiz question.
Prabhu, can we have the slide? Prabhu, you're there?
Around minutes.
Basically, we had a very good 4 lectures. The first one was most surgical. So as surgeons, we'll be asking you only on surgery. That was asked or told during the lecture. The question is, what is the Frickman-Goldberg procedure? Among all the rectal prolapse surgery, which one is the Frickman-Goldberg procedure, which is very commonly done procedure, and which one you just have to name it. You've got 2 minutes to do it. This will be seen for the next 10 seconds probably, and you have got 2 minutes to answer this. Thank you. I think we can move on to the question answers. Kothari sir and Dr. Bikal, I think you can go on with the questions if you have any.
Hello.
Rajdeep, I request you to kindly forward the questions if there are any.
Yeah, I've been forwarding the questions. So we can start with Dr. Kothari, whatever questions he has.
I'll just look at the WhatsApp because I was involved in listening to.
It's not on WhatsApp, it's on the chat group, sir.
I think Rajdeep, you can ask the questions also itself.
Okay.
Yeah,
Then I can have one question for Dr. Sanjeev Patankar. That what are his points for decision making for resection rectopexy and without resection rectopexy? And another question, because in his series, most of his procedures was ultimate procedure, probably because the patients were unfit for abdominal surgery. But in Alzheimer's, you are forced to do the resection rectopexy, whether it is indicated or not indicated.
Great questions. So the first question, when you are doing an abdominal procedure, do you add a resection rectopexy or not? The standard decision tree protocol that was taught to me was that, and I did not allude to it earlier because this requires further analysis of the pelvic floor, the constipation, the slow transit constipation, the colon transit studies. So if a patient has severe constipation associated with rectal prolapse, and you have done colon transit study, which shows that it is mainly the pelvic, the lower and the left compartment, then doing a resection rectopexy can substantially improve the chances of improving both, correcting both the rectal prolapse as well as the associated constipation. I want to again emphasize that surgical procedures should be considered only when you have an external prolapse. If you have, Dr. Manto has covered very beautifully that if you have predominantly symptoms, there is a disconnect between the severity and the symptoms. So if you have predominantly symptoms and only grade 1 internal prolapse, intussusception that you see, those are the patients that need to be properly treated in a multidisciplinary environment. Overall, there has been a trend. So the other thing is when you are doing a laparoscopic procedure, if there is a very substantial redundancy of the sigmoid and the rectum, in those patients as well, one would consider adding a resection rectopexy. So that's the main thing. If there is associated severe constipation, add a resection rectopexy. It does add a substantial degree of risk to the procedure. Having all stapling instruments will make the procedure safer so that you are not having any contamination during the procedure. You are absolutely right that when you do a perineal procedure, a transanal procedure, it is when you do an Altmaier, it is of necessity a resectional procedure. Yes. It is a full thickness resection. Personal experience, I think, is what leads to comfort. Having, in our fellowship in Orlando, there were 6 colorectal surgeons. And in addition to that, we used to travel at least 30, 40 miles once every week to see another surgeon who was kind of in our teaching program, but without being affiliated directly. So we saw different types of procedures. I did see DeLong, but the perineal proctosigmoidectomy that I saw, and Dr. Larash taught it to us, was just, it was wonderful. There is a learning curve to that. I would say the learning curve is to actually see and assist in about 10 cases, and then roughly 10 more cases for you to learn. It is not a difficult procedure. And although there is a perineal, there is a proctosigmoidectomy, the procedure, the anastomosis is so low. You see, the anastomosis is well below the pelvic floor. If you are careful with the anterior anastomosis line, anteriorly you are going through the peritoneum. I have had a young patient who referred this particular procedure for her own personal reasons. She said, I don't want to have a single scar on my abdomen. My beauty of the abdomen is my source of income. The almost 1.5 feet of sigmoid was resected. So it's an easy procedure. It's not very hard. If you use the Lone Star retractor, the hooks, and the ligature, the division of the mesentery is pretty straightforward. And when you have the sigmoid coming through, and once you take away all the redundancy, you start taking just 1/4, or even 1/8 of the circumference, do the anastomy, put the sutures. So that way the sigmoid does not recede back into the abdomen. So yes, it is by definition, but it works very well. And it is one of the procedures that is very frequently done.
Yes. And how do you preserve nerves while doing Alzheimer's?
That is a great question. You are, it's a transanal procedure. So you're not going into, the only thing that you are going into is just the posterior mesorectum. So you are you're not anywhere into the perineum at all, really speaking, into the perirectal areas. You are basically just coning down into that.
And if the patient has portal hypertension, then do you find some different difficulties?
Yes, I mean,
because
those are...
One of the patient I was called to do a Alzheimer's, and I was not aware that he has portal hypertension. There was a lot of bleeding because there were large vessels.
That's a nightmare. I think they called the right surgeon, the expert. These are nightmare situations.
Yes.
Honestly, I must say I have not encountered portal hypertension. Substantial portal hypertension and even abdominal surgery can be very difficult.
Yes.
I have situations where you see these arterialized veins.
Right.
And it's a tough operation, whether you do perineally or you do other ways. The other very difficult situation that I have encountered personally was a patient who had Crohn's disease and rectal. So obviously, I did not choose a resectional rectopexy. I did an abdominal only rectopexy.
Right.
So there's a question which has come in younger patients. Probably he means the 20 to 30-year-olds. Is there any difference, or would you still prefer an Altmaier then?
In younger patients of this age, I personally would never choose Altmaiers. I would choose an abdominal procedure. It is only 2 patients where in my entire series where I was forced by the patient, so talking to the patient is important. As I said, one of these patients was 25-year-old, I believe. Either she was some type of a belly dancer or some profession into the dark areas of the society. And we go through, these are the options, and I recommended at that time, the robot wasn't available, but I said laparoscopic procedure, 3-4 minor, small, 1 centimeter long scars. Occasionally, there is a need for a small suprapubic incision, and she got upset. She stood up, dropped her clothes, and said, "This is my source of income. I do not want a single scar on it." So I was forced to do. So I would not. Young people typically will have good functional results. The laparoscopic and robotic procedures give excellent. All that you have are just if you use 5mm trocars for the laparoscope, I mean, at the end, there is really nothing if you are not adding resection. So I wouldn't choose it for that.
Very well said. There's another similar question that a higher number of Ottmeyers in your series was due to patients who could not tolerate surgery or because of their age?
Both. I mean, if you see the average age, the mean age was 85 up to 102-year-old. So of necessity, these were patients who were not moribund. They had multiple abnormalities, but they were not like bedridden patients. They would have either walker that they would use. Then some of them would be living in the senior care homes. Then once a week they go to play games, the housey, they visit of necessity, multiple medical comorbidities are to be expected in this age group. So geriatric age group patients. So the kind of, that's why I said demographics of the area and the aging population in US. Now, Dr. Chandra has observed that in Lucknow, a number of the patients that he sees are young people. And I think we just need more documentation from you guys. Our population of India is so huge. You have such a large multiplier that I think individually, if you see, you may not have that many patients. But if we do a collaborative effort, we could get some really big numbers and come out with some nice articles. So it's a combination. Patients who are really old, then of necessity, they have the medical comorbidities.
Another similar question, in male patients, is there any change of management? Most of I think the pictures you showed were of women. So in men, would you change the management?
No, I mean, if many of my elderly patients, there were males as well, and Altmeier's is equally easy to do. One thing I want to say, and I would like Dr. Mantu's, I think he would probably agree with me, the levatorplasty is a very unphysiologic procedure. We do not want to do levatorplasty. In females, it can lead to sexual issues. So I have relied in male patients, it is an easier operation, actually speaking, and procedure was no different.
Okay, so another question, you have partially answered this earlier. If a patient has a weak sphincter tone and a prolapse, should we go ahead with surgery or not?
Yes, absolutely. If there is a full thickness rectal prolapse, external rectal prolapse, go ahead, have the patient for surgery, fully evaluate the patient. Every patient, in my opinion, should have, because as has been alluded to before, if it is a female, there could be other compartment abnormality. You need to have documentation. So you should do a rectal physiology studies, manometry, rectal compliance, pudendal nerve terminal motor latency, because it gives you some prognostication as well. So have the full documentation. MR difficography is the procedure to go for. Then schedule the patient, for the rectal prolapse. Do the rectal prolapse, allow let's say the perineal proctosigmoidectomy, allow the suture line to heal up. After about a month or so, you reevaluate.
Dr. Patankar, if you allow me to add a comment here.
Please.
We have in patients with rectal prolapse, if you have a poor rectal function, one of the drawbacks for transanal procedures is that it worsens the incontinence.
Absolutely.
You need to warn the patients that your incontinence will be worsened. So for older patients, that may be okay. But you need to document and warn them that, your incontinence will worsen. But for younger patients, that's one of the, points where we prefer to offer them transabdominal procedures because you don't want to worsen the incontinence.
I totally agree with you, but we are saying exactly the same thing. For younger patients, you would not offer a perineal procedure, a transanal procedure. And in older patients who can't tolerate abdominal procedures, what other option do you have to do the repair? Because many times the incontinence could be pseudo incontinence. It is just the mucus that keeps leaking out. So you have to document, you have to repair. Unless you repair, you can't go anywhere. And then the biofeedback and the multidisciplinary, the thickening, I wouldn't do and recommend a concomitant sphincter repair. So I think we are both highlighting exactly the same important things. Full evaluation of the total global pelvic floor. Consider the whole thing as a global pelvic floor.
So that takes me very well onto the next question which has come, which is open to all the moderators as well as the speakers. Are physiological studies and difficography required in all patients who have an obvious prolapse? They can see there's a prolapse. Do we need to do all these things?
I always have said yes.
I think I tried to emphasize that in my talk that, pelvic floor disorders rarely occur in isolation. In fact, when you have an obvious full thickness rectal prolapse, especially in a female, it's likely that they may have either uterine prolapse or even cystocele. So when you fix the rectal prolapse and you have not evaluated the middle and the interior compartments, it is probably that they will come with symptoms of the urinary incontinence or even vaginal prolapse after you fix the. And then comes the problem, if you have operated the patient, how to fix this middle or the anterior compartment now, if you want to fix it, trans-abdominally. So if you have a double incontinence or double prolapse, middle and the posterior compartment, we can do what is called dual mesh ventral rectopexy. That means you put one mesh in front of the rectum and one mesh in front of the vagina, which can be done at the same time, provided we have done an evaluation before and recognize the problem. So I would suggest it is important to evaluate the whole pelvic floor rather than just go by the clinical presentation.
I wholeheartedly second that. It is one of the most important principles. And doing one surgery, just the posterior compartment, and then subjecting the patient a few months later by a urogyn or gynecologist for something else is going to add difficulty for the other. So that's where the collaboration and doing along with urogynecologists or a urologist makes importance. Absolutely, very important. I would not omit this unless there are situations you are in a rural area but no.
Because what is your practice?
I always recommend it and got it.
Great. Dr. Bhandari?
Yes, one question to Dr. Manto, that while doing the anterior rectopexy in a patient 40 plus with some uterine fibroid or something, does he allow the hysterectomy to be done by gynecologist or the hysterectomy to be done later? And if the hysterectomy is done later, does it cause any difficulty in doing the hysterectomy later after doing the anterior rectopexy?
Well, that's a very good and practical question, I would say. If patient has got, fibroids, like we do anterior sections even in patients with fibroids, and we can hitch up the uterus. It's not difficult to do a ventral mesh rectopexy, even if there's but if the patient is symptomatic for the uterine, fibroids first, then we should treat the disease which is symptomatic. That means we do a hysterectomy first, and later on, we can go for a ventral mesh rectopexy. And it's possible, that's my assumption only, that when you do a hysterectomy, these are functional disorders sometimes, it may improve the symptoms of the patient. So you can observe the patient after hysterectomy because that has been done for a disorder for which the patient was symptomatic. So it is perfectly all right. You can observe the patient over a period of time, and if patient still has prolapse disorders, you can still offer in fact, it is easier to do when there is no uterus. You can imagine you have more space to operate there.
I know. But you don't like to combine both the procedures together?
No, not really. We wouldn't, because you're putting in a mesh.
Yes.
And you are worried about infection, and once mesh gets infected, is a problem for life.
So the hysterectomy first and later, if the symptoms
But if the
do not
patient
resolve.
is symptomatic for the fibroids and it's just an incidental finding, you can proceed with the ventral mesh rectopexy first.
Okay.
So Dr. Mantu, in the video you had shown, is no posterior dissection done in ventral rectopexy?
No. So, yeah, that's the advantage of ventral mesh rectopexy. You just do a right-sided dissection along the right border of the rectum from the promontory all the way to the pouch of Douglas. And this dissection is just deep enough where you can bury in the long limb of the mesh and you can cover it with the peritoneum. The main dissection is in front of the rectum, deep in the pouch, where you do a lateral dissection on both sides to expose the levators. And then you can fix the mesh to the levators and to the rectum, and then hitch up the the mesh to the sacral promontory. So there's no dissection, there's no denervation, and that's why there's no risk of worsening the constipation as is done when you do a posterior rectopexy or even a resection rectopexy, where you, even if you want to avoid, you will still, damage some nerves, and there's possibility of worsening the constipation.
I have a question for Dr. Mantu. I have a question. Posteriorly, we have the sympathetic nerves, and the parasympathetic plexus is much further down and at the level of the Denon-Velius fascia and in that region. Your anterior rectopexy that by definition requires dissection so far down, has you observed more parasympathetic issues, the erectile issues, as opposed to the...
Well, that is true for male patients, because we know that, but fortunately we don't have many male patients who have this pelvic floor disorders. So ventral mesh rectopexy works perfectly for females without much functional disturbance, I would say. But for male patients, yes, I agree, because if you do dissection close to the prostate, there's a risk of denervation, especially the sympathetic nerves. You may denervate and you may risk sexual. But most of these patients are past their 50s, in the middle age. They would not worry much about that. But fortunately, we don't have any patients.
Well, the reports that we read, female sexuality is also substantially affected. It's hard for us to imagine, but the article suggests the same.
That's exactly true, because I worked in France, where they are very conscious about the functional outcomes.
Right.
There you have got 60-year-old, 70-year-old females who are sexually active. They're very concerned about their functional outcomes. Fortunately, working in Asia, it's still a taboo. Most females past their 60s wouldn't talk about it. That's an advantage to us, but in reality, yes, it is an issue, but many patients don't talk about it. But having said that, with ventral mesh rectopexy, actually you don't have much functional disturbances in comparison to the resection as well as the posterior. We know from our experience of low anterior sections, the LARS and urinary problems, sexual problems, that's why I've moved to ventral mesh rectopexy, which gives minimal functional disturbances.
And I think that is the way to go for the residents in training and fellows. I think one should, at that stage, one should become familiar with these important concepts, right? I mean, a question was asked about good.
And especially with the introduction of the biologic meshes,
yes,
it has made life simpler, easier, because prosthetic meshes still have problems, but biologic meshes after a few years become like normal tissue, so even if these patients develop cancers in future, so far there are no reports, but whatever personal communications I have with my colleagues in Europe, they say that it doesn't create much problem even if you need to do a low anterior section and if these patients develop cancers in future.
There is a question whether any special pre-op preparation is required. I think he is talking about bowel preparation.
Yeah, I would say it is preferable to give a bowel preparation because there's always a risk of making a rectal rent or even a vaginal rent during this procedure. There is always, of course, we try to avoid it. But if you have a good bowel preparation, you can wash the area, suture it, and then you can still carry on with the procedure. But if you don't have a bowel preparation and there is a lot of contamination, although fortunately I didn't have to do it, you may even have to abandon the procedure. And you may not want to put in a mesh there.
And in Altmaier, it's probably mandatory. No.
See, with bowel prep, we have gone, it's been a pendulum, right? Even for resections, laparoscopic resections, do bowel prep, 3-day bowel prep and 2 days of antibiotics. Then came the pendulum, don't do at all. I personally navigated through those times. I always wanted to have the colon. An empty colon is much easier to handle, as you have observed, sir. Doing laparoscopy, robotic surgery, empty colon is easier to handle. And yes, so we used to do bowel prep. It doesn't need to be intense. Really speaking, it can, Altmaier's in some patients I have done with basically max sedation. The physiologic impact, if you are careful with the tugging, the sympathetic stimulation during that will drop the blood pressure of the patient is not much. So, and most of the time, the rectum is actually empty.
Right. So you have already, Dr. Mantu mentioned about the typical history. I think we can skip that. The question is, prolapse invariably associated with the ODS, obstructive defecation syndrome?
I wouldn't say prolapse, but yes, rectocele can be associated with the, it was very well shown by Dr. Ravi in a slide that you have two types of ODS, one with an anatomical abnormality, one without an anatomical abnormality, where you have mainly like puberectalis paradoxical, which or other, you have an anatomical abnormality, which is usually a rectocele, which can lead to ODS. And yeah, in those patients, you can offer surgical correction. Have I answered the question?
Yeah, satisfies me. So, Dr. Ravi, there is a question for you for the dynamic MRI which you had shown. Is it some special add-on or it's available in the most MRI machines which are available?
No, it's available in all the 1.5 Tesla MRI machines. It's a routine sequence which is readily available. It's only the radiologist has to be ready to allow a patient to defecate on his 4 crore MRI machine. But believe me, it is not so much of an issue. We put an adult diaper on the patient and there is never any soiling, because actually a soiling would be an electric risk also, because the coils are all electromagnetic. So there is a proper maneuver of doing it. We put the adult diaper and there is never any soiling. And what comes out is generally the ultrasound jelly which you have instilled. So that is it. So it's more of the resistance on the part of the radiologist, but there is no new sequence. It's available in all the machines.
Thank you, Dr. Ravi. So the last question is from Dr. Mayan Gupta, who is one of our EC members. He is asking whether following a sutured lap rectopexy, a young patient developed constipation. How should he go about managing this patient?
Can I say, refer to Miss Archana? And I must congratulate her for a very good lecture, and very important details about the biofeedback. And she's the right person to answer it, because as a surgeon, you may not have much options for that patient.
Absolutely.
Thank you, sir. Sir, can you repeat the question? Am I audible?
Yeah.
No, it was not a question. He was just commenting on the excellent presentation you had given.
Okay. Thank you, sir. Thank you so much.
No, the question was if a patient undergoes a suture rectopexy, right? And patient does not have relief of constipation. So what do we do next?
So if he's referred to me, generally we start with diet modification, because we need to start first with the diet modification so that the exercise, whatever protocol we are giving them, it works well with that. Because otherwise, if the diet is not followed, the patient will be constipated and will be straining to evacuate. And at the same time, I'll be working on training his pelvic floor. So first we start with diet modification and then we go with the pelvic floor training.
Okay.
I think that's what I will do. I will probably physiotherapist as well.
Very true. Functional disorders, this is mainly a functional issue. They are very hard. I already kind of indicated that I used to escape from ever operating on ODS patients. We don't do, by a show of hands, STAR procedure is not done by almost any colorectal surgeon in US. And ODS patients with just grade 1 and constipation, you operate on them, they are like an albatross around your neck. So stay away.
One of my mentors used to say that you should never offer a surgical procedure for a functional disorder. It should be the patient who should repeatedly, not once, but repeatedly ask for it. And when all the options are exhausted. So because most of the times outcomes are not very satisfactory. And once a patient, it's always a patient for you.
And even referral to gastroenterologist can help. They once upon a time, I know that total colectomy has been done for slow transit constipation, and
I've done it. But that's after that patient followed me up almost for a year, and we had done a scan. He used to come with severe abdominal bloating. I have some remarkable CT scan pictures where the abdomen is just replaced by, fecally loaded colon, and he had no other options. And fortunately, he had a good outcome. Once we removed the whole colon, he had a good outcome. These are very rare cases, not very common.
If we are towards the end, I would just like to share a small personal experience that I had. Victor Fazio, most everybody has heard about Victor Fazio. He is late Victor Fazio. He was the chief of Cleveland Clinic, Ohio, a fantastic surgeon. And he had come as a visiting professor at Robert Wood Johnson University Hospital. And the residents had presented various cases, and somebody asked him about this question about what he does, what is his protocol for managing patients with severe constipation due to slow transit constipation. And so what does the big professor state? He says that I send these patients to my colleagues. So if I knew Dr. Manto is a pelvic floor specialist, you would have gotten a number of referrals from me. These are very difficult patients to, and one should stay away as a surgeon. Rely on diet, on physiotherapy, on gastroenterologists. Many nice motility agents are available now.
Yes, thank you, sir. Any questions, Dr. Kothari, Dr. Bikal?
No, it was a great interaction. Great interaction.
I have one last question to both the surgeons. So, what is your preference of mesh and preparation of mesh for the rectopexy? So, do you like some prefer to reduce it to 1/3 of the circumference of the rectum? Some do with J lobe. So, what would you prefer the mesh?
I do not, do any special preparation for the mesh, especially for the biologic mesh. We just use it as it comes. We just put it in normal saline to soften it a bit, and that's it. Then it becomes a bit more softer and easier to use. And I do not use sutures on the one problem with biologic mesh, they are very tough to suture. So we use the tackers, the absorbable tackers, to tack it to the levators. And only sometimes I even tack it to the sacral promontory as well. But the problem is that you may run the risk of bleeding because it's a blind tacking. So I prefer to put a suture, but it's easier to suture near the promontory rather than deep into the pelvis. For the synthetic mesh, again, no special preparation. I don't dip it in any antiseptic, or I just use it as it comes, because it comes in a sterile pack. I just cut it into the shape I want it to use, and that's it.
So what's your
Dr. Manto, his question was different. His question was, how do you design, how do you tailor the mesh? Do you...
Okay, sorry, I didn't show a picture. I design it in like you can say like a L shape. L, the horizontal L is about maybe 7 to 8 centimeters, which goes deep into the pelvis and covers the anterior rectum and reaches, it must reach to the both levators on the sides and cover the rectum. And the long limb is dependent on the patient's height, so it must reach. So I leave it long. I leave it longer than the sacral promontory, suture it first, and then trim the remaining part if there is an excess part. So I would say a 9 by 20 or 10 by 20 cm mesh will suffice in most of the patients, especially Asian patients. 10 by 20 cm should be enough for most of the patients. Does that answer the question?
Yeah. Thank you, sir.
Right. Dr. Mantu, another thing you showed that you do not suture the rectum at all. I missed that.
Yes.
So, I don't think that is the common practice, or it's the usual practice.
Well, the original procedure, which was devised by the whole reference was given by Dr. Patankar. They suture it to the rectum. It's easier to suture when you're doing it robotically, but laparoscopically, there is always a fear that you may take a deeper bite or even lacerate the rectum. So the center where I did my fellowship, they modified the technique and they fix the mesh to the levators, and that's what the technique I learned, and I'm practicing it. Dr. Roy had sent a fellow to my center. He trained with the same technique, and Dr. Roy is practicing with the same technique of not suturing to the rectum. And he has also, whenever we communicate, he says he has got good results, no issues with the patients. It makes life a bit easier because suturing deep into the pelvis onto the rectum can be challenging laparoscopically. But if you're using a robot, I would encourage, rather suggest to suture it to the rectum because it's much easier.
Thank you, Dr. Mantu. Thank you, Dr. Sajeev Patankar, Dr. Ravi Thapar, Ms. Archana Rege. Excellent lectures. Everybody was engrossed. Dr. Kothari and Dr. Bikal, you were excellent moderators for the sessions. Dr. Debarshi, I hand it over to you.
Thank you, Rajdeep. I think it was an extensive. We rarely have 2-hour long sessions. Actually, we nearly touched 2 hours. Today, we went across 2 hours by quite some time. Thank you all of it. I have some few announcements to be made. I would like to also say that this time we've had very good response to the quiz, and from MCH residents, we have 2 winners who are postgraduates this time. One from Salem and one from Delhi. So we will announce the names. They have to be there the next time also. I will inform them in the due time. Can we have the slides for the announcements, MRC announcements, which are coming up? The next online CME is on the 3rd of August. That is the first Thursday of the month. We'll have it again at 8 p.m. The speaker will be Dr. Krish Manan, who is a consultant liver surgeon in King's College London. He'll be speaking on minimally invasive liver surgery, and it will be moderated. This time we'll be doing it with the Bangladesh Society. Last time we did it with the Sri Lankan Society. This time with the Nepal Surgical Society. Next time we'll be doing it with the Bangladesh Surgical Society. It will be moderated by Dr. Noor Hussain, who is a secretary from there, along with Dr. Ovi Sudhir, who is a head of GI surgery in Amrita Kochi, and Dr. Anand Vijay, who is a liver transplant surgeon in GEM, Chennai. And it will be convened by Dr. Jagdish, who is the South Zone Vice President. Now, moving on from the CMEs, we'll have our MRC Lens, which is actually the operative surgery CME or operative surgery workshop. The first, again, we'll start with our founder, President, Dr. C. Palnivelu, sir. It will be on, this is being planned on the 3rd Thursday of every month. But instead of 8 p.m., it will start at around 3 p.m. Indian time, and it will move on till around 6 p.m. in Indian time. That will be a 3-hour operative session. Yes, sir?
Are you sharing the screen? We are not seeing anything.
Actually, Prabhu was supposed to share the screen, so Prabhu is not there. Acha. Can you move on? Yeah, next one, Prabhu. Yeah, this is what I was talking about. this will be on the 20th of July, basically next week. This CME, we had to postpone it for laprosurge. So this, the Amasi lens, which will be an operative surgery CME, it will be on the 20th of July, the first one, and we'll move on every third Thursday of every month. And this is going to start at 3 p.m. and move on till around 6 in the evening. Today, first will be on laparoscopic right hemicolectomy, which will be shown by Dr. C. Palnivalu sir, our founder president from GEM Coimbatore, probably. And then we'll move on. This will be supported by Healthium company. We're moving on to our smart course lectures, smart course courses, which we have. This is the program. I think it's better. I cannot expand on all of them. It's better that everybody goes to the website. These are the programs which are coming up. But finally, I'd like to talk a little bit about AmasiCon. AmasiCon is our landmark, our main conference, which we hope will be a landmark event this time. It'll be from the 2nd to the 5th. Many workshops are organized, many live surgeries, many programs. All are being organized here. I'll request all of you to visit amasicon2023.com and get yourself registered for the workshop as well as the conference itself. We also have a few upcoming skill courses, which the next one is in Bhubaneswar in the last week of July. Then we have in Kochi in the middle of August, and in Ranchi in the later part of September. We have another course abroad. After the Sri Lanka course, we have the next abroad course is in Nepal, which starts from the 29th of September till the 1st of October. I take this privilege also to, again, first I'd like to welcome all of you to these programs which Amasi is having. I would like all of you to participate in that. And also, after Rajdeep, I would like to thank all the speakers, all the 4 speakers. Dr. Varghese, sir, would you like to say something?
No, that's all, Devoshit. Thank you very much. Thank you.
Thank you all. All the 4 speakers were all very extensive, and we would like to see all of you during AmasiCon also. Thank you.
Thank you very much. It was a wonderful.
Thank you very much.